So thanks very much for coming, guys. So my name is Becky Sedman, I'm the lead night vet, and I'm currently doing my BSAVA ECC certificate. So I'm going to be speaking to you tonight about the DKA emergency and kind of a step-by-step approach to managing these patients. So who of you enjoy managing DKAs? Hands up? No? Who hates it? Okay. Who doesn't mind?
I'm in the middle.
In the middle?
Yeah.
Okay,
It
cool.
confuses me.
Well, I'm hoping we're going to go through everything fairly logically, and we'll do a very brief overview as to the pathophysiology first. So obviously these patients have diabetes mellitus, so they're going to present hyperglycemic, but as well as having the diabetes, there's also got to be the concurrent upregulation of counter hormones to trigger ketogenesis and then tip them into DKA. So the counter hormones are things like growth hormone, cortisol, glucagon, or catecholamines. And basically, when the body's been without glucose for a period of time, the cells look to utilise an alternative energy source. And that alternative energy source is ketone bodies. So ketone bodies are produced with the breakdown of fat, also known as lipolysis. And then this then generates ketones, so ketogenesis. And it's a fairly decent energy source. Brain's pretty good at utilising ketones, but the downside is that when they build up in great kind of a significant amount in the body, they are also acids, so then you get this acidosis and the consequences of that. Now, often with diabetic patients, because they're excreting so much glucose in their urine, you get the osmotic diuresis effect, and it drags all of the electrolytes with the glucose. So these patients often already present as hypokalemic, potentially low phosphorus levels, potentially low magnesium levels, and obviously they're losing an awful lot of water. Now, when they're well, they can actually kind of counter this by being polydipsic, but in times of illness, they might not be drinking as much, might be having GI losses, so they then very quickly get severely dehydrated and hypovolemic as well. So your classic history is patients that present with diabetes or signs suggestive of diabetes. They may actually already be on insulin, and then they can still develop DKA, or they may be undiagnosed diabetics at this point. So POPD, weight loss, increased appetite, and then they've also got a period of acute illness. So they might present lethargic, inappetent, GI signs, whether they maybe have pancreatitis or they might have a UTI, and that acute illness could be the thing that then tips them into the DKA crisis. So on clinical exam, these patients will present with hypovolemic shock. So hypovolemia is the loss of water from the intravascular space. So the body can compensate to some extent. The patients will present as tachycardic, although cats often present in shock bradycardic, so don't be caught out by that. Pale mucous membranes, prolonged CRT, and cold extremities because of all the vasoconstriction that's happening in the capillary beds to just try and maintain that blood pressure within the kind of main arteries. They also have weak pulses, reduced mentation, and then that's kind of your more critical aspect, the hypovolemic shock, which we need to address straight away. But they're also concurrently going to be dehydrated. So they might have skin tents, they might have tachy or dry mucous membranes, and they may also have other clinical signs associated with the comorbidities. So it's really important to do a thorough clinical exam and figure out exactly what could be going on in addition to the diabetes. So really straightforward to make the diagnosis of a DKA. You need three things: presence of diabetes mellitus, so they'll be hyperglycemic. The only instance in which they might not be hyperglycemic is if it's a cat that's on Senvelgo. So they present as euglycemic DKA, but we'll talk about that later on. Metabolic acidosis, as per the blood gas analysis, and also the presence of ketones as well. So the body makes three main types of ketones. The production of ketones alone in a well patient isn't that much of a red flag, but it's the presence of ketone bodies in an unwell patient that's also acidotic that is the red flag. But it's worth just knowing that the body can produce three main types of ketone bodies. So the first is acetone, and that's what gives the breath a pear drop smell. The second is acetoacetate, and that's what you would detect on the urine dipsticks. So you can actually use the dipsticks on urine, or you can use it on serum. And then the most prolific ketone body is beta-hydroxybutyrate. So that's actually what you detect on the handheld ketone meter. So if you've got the handheld ketone meter, this is our cut-off. So cats it's over 2.5 and dogs it's over 3.8 millimoles per litre. And to be honest, it's best to, if you've got a ketone meter, this is kind of the gold standard to detect ketone bodies, because as I say, it detects the most prolific ketone, whereas your dipsticks, there is a risk of false negatives, because it might be that the patient hasn't quite started producing the acetoacetate yet. So we need to do a blood gas analysis. Venous sample is absolutely fine. We tend to use the arterial blood gases if we're worried about oxygenation or if the patient's got ventilatory issues. But typically venous absolutely fine to check for evidence of metabolic acidosis. So that would look like a pH of below 7.35, negative base excess, plus or minus decreased bicarbonate. And often when you've got patients with metabolic acidosis, they can have a compensatory respiratory alkalosis as well. So I've just put a note here, if you don't have access to any sort of ketone meter, you can calculate the anion gap in diabetic acidotic patients. And so long as we know that there's no history of kind of toxin ingestion, like your ethylene glycol specifically, or hyperlactatemia, if you've got an increased anion gap of above 25, that's kind of evidence to get started on your DKA treatment. So other biochemical findings we might see in these patients, talked about hyperglycemia, ALPs often increase with systemic inflammation. Hypokalemia is pretty common when they first present because of the kind of ongoing potassium losses in diabetic patients, but also if they've had any GI loss or reduced intake if they're not eating, that can actually worsen it at point of presentation. But as well, as soon as we start these patients on insulin, it's going to get a lot worse. So we need to be supplementing the potassium as kind of our first ports of call. As well as other electrolyte deficiencies, typically magnesium and your phosphate as well is pretty low. Total solids likely increase due to dehydration or hypovolemia, and you can get either a genuine hyponatremia or you can get what we call a pseudo-hyponatremia due to the altered osmolarity. So the osmolarity being like the amount of solute in the bloodstream. So to get really technical, if you want to try and work out the difference, there is a special sodium calculation for that. But it's just more so, I suppose, if they present particularly hyponatremic, you want to be fairly cautious with how quickly that sodium level creeps up to avoid any neurological issues. Also azotemia, now could be pre-renal, could be renal. Your USG is not going to help you that much in working out the difference. So ultimately fluid resuscitate these patients and then recheck the kidney values in 24 to 48 hours and see where you're at. Further diagnostics, not necessarily a priority, but while they're hospitalised, you want to work out what the comorbidities might be to have tipped these patients into a DKA crisis. So we would always do a urinalysis and microscopy. So a dipstick alone, not very useful to be honest, but together, if you're seeing the presence of bacteria on the microscope or white blood cells, that will be enough evidence for me to then get started on antibiotics. If it looks like there's no UTI, or if there is a UTI, I'd still probably be sending away urine for culture as well. Checking for pancreatitis with FPLI or CPLI, depending on whether they're a cat or a dog. Looking at the heme biochem or chest and abdo imaging to look for any systemic disease, be that infection or neoplastic disease or some other inflammatory condition. The other thing that we sometimes do is in our cats a quick brief echo just to work out if the cat actually has any subclinical HCM. So if you can work out a quick left atrial to aortic ratio, if that's increased kind of above 1.6, then we know that these cats might be more susceptible to fluid overload. So we need to be really kind of careful and monitor them really closely. Cortisol testing as well. Often our diabetic patients have Cushing's, but there's no point doing any sort of cortisol Cushing's testing while they're poorly, and actually it's not a priority. Just focus on the DKA management, and then when we've got through that, then you can look at testing for Cushing's and treating if needed. So the treatment strategy. So a brief overview, but we'll go through all of these points in more detail in a minute or two. First things first, correct hypovolemic shock. We do that with bolus fluids, with Hartmann's, so that's a really nice balanced crystalloid. Second, correct or prevent worsening hypokalemia. Third, we need to be starting a neutral insulin protocol. So neutral insulin is also called regular insulin or short-acting or soluble insulin. I don't know why it's got so many names, but it's all the same thing. The brand we have is Act Rapid, which is a human insulin. Then you can do it either via a CRI or you can do it via the intramuscular protocol. What would you guys typically use, IM or CRI? At Westwood, do you know?
Only ever used IM.
IM.
Not at Westwood.
Okay, cool, fine. Well, we'll go through both anyway. So then we want to also be correcting the dehydration over 12 to 24 hours. We want to be correcting any electrolyte disturbances. So we talked about particularly your magnesium and your phosphate. Correcting any refractory metabolic acidosis. Now, hopefully, the acidosis should resolve itself when we're getting on top of the DKA and obviously stopping the body from producing these ketone bodies and metabolizing the ketone bodies that are in existence. But if you've got a really stubborn acidosis, then we can give bicarb, and we'll talk about that in a second. And of course, any other supportive treatment as tailored to the individual patient, whether it's pain relief, antibiotics for a known infection, antiemetics, or anything else that you feel that patient requires. So we always like to put at least two IV lines into our patients because they're on multiple CRIs, and we're talking like sometimes 4 or 5 CRIs. They can be quite intense to manage. A central line is really, really useful because central line being a jugular IV, not only can you put the CRIs onto the central line and it lasts for a long time in the patient, but actually you can blood sample directly from the central line as well, just to minimise the number of times you're sticking the patient. Always care with fluid overload due to the multiple CRIs, so we need to be totting up what the overall fluid rate our patients are getting. And signs of fluid overload may well be an increased breathing rate, serous nasal discharge, peripheral edema, and the classic sign is kind of over the gastrocnemius tendon, that can feel a little bit puffy, or chemosis. And if you're noticing any signs of that, then you just need to back off with your fluid delivery. And then if you're anticipating a period of ongoing anorexia, then a feeding tube may be warranted. So, correcting shock first and foremost. So, as we said, DKA patients present with hypovolemia, which is loss of fluid from the intravascular space. And the problem is, when there's not enough kind of circulating blood volume, although the body compensates to some extent, it will then decompensate and you get hypoperfusion of the extremities. And when the cells just aren't getting the nutrients and the oxygen they need, they then switch to anaerobic metabolism. Product of anaerobic metabolism is lactate. Lactic acid is obviously an acid, so then it contributes to the acidosis. So hence fluids are super important in these patients. And generally they are most critical when they're the most shocking. So hence that's kind of our first priority. Give them a few fluid boluses, bring that heart rate down, and make sure the blood pressure is adequate. So we want to use a buffered isotonic crystalloid, really good for acidotic patients. And to give a bolus, cats we tend to use 5 ml per kilo over 10 minutes. Dogs we tend to use 10 ml per kilo over 10 minutes. So give a bolus, check the perfusion parameters. If you think they need another bolus, give 2 or 3. Obviously just more caution, be a bit more cautious in cats than with dogs. And when you guys bolus, do you use the fluid pumps to do it? Yeah, perfect. So you can obviously do it with a fluid pump, or you can set a timer and then check after 10 minutes or so. But to be honest, most patients that walk through the doors get boluses, so really beneficial. And then next is correcting dehydration. So the difference being that dehydration is a loss of fluid within the cells and in the interstitial space. So we want to be replacing that over a longer time frame, over 12 to 24 hours. So if you calculate what the fluid rate is needed to correct the percentage dehydration as decided on the clinical exam, and I'd say actually as a ballpark most of the DKA patients are at least 10% dehydrated, you then know overall what that patient needs per hour, and you can work backwards with working out what they're getting in terms of CRIs, and maybe topping up with just some standard Hartmann's to make sure we're addressing the dehydration as well. So fluid rate being maintenance requirements plus dehydration requirements plus ongoing losses, and obviously these patients are very polyuric, so they do have quite significant ongoing losses. Supplementing potassium next. So I'm sure everyone's very familiar with supplementing potassium. I just tend to go off one of the tables that we all have saved in our phones, and it's exactly the same for DKA patients. I would just say that I personally don't like to start treatment until the potassium is over 3.5, just because I know it's going to plummet as soon as we start the insulin therapy. So if that means from the time of admission to then starting insulin, it's kind of 6 hours or so, because I've been concentrating on correcting the shock and getting the patient more hydrated and correcting the potassium, I'm okay with that, because I don't want to be starting the insulin until the patients are, until I know that's going to actually exacerbate the situation rather than make it better. So the reason that we get hypokalemia after starting therapy is because the insulin works on the sodium potassium ATPase pump, so it then drives glucose into the cells, but with the glucose it also drives potassium. Obviously the counter, I don't know what I'm trying to say. This is why also in patients where they're severely hyperkalemic, we use insulin and glucose to try and drop the potassium levels. It's exactly the same mechanism, just kind of two ends of the spectrum. With your potassium supplementation, make sure that's in a separate CRI bag, make sure it's labelled correctly so everyone knows it's got potassium in it, and obviously do not bolus, and make sure we don't exceed that correction rate of 0.5 millimole per kilo per hour. I would say in DKA patients, because the potassium drops so quickly, I actually often do tend to double the potassium concentration in the bag, just so I can give them a slightly fluid rate but deliver the same amount of potassium. But you just got to really make sure that it's evident everywhere that it's a double concentration, so the next person that looks after the patient doesn't accidentally overdose them. So that's the table, in case anybody needed it. All good? Pictures? Yeah. So to give you an overview as to the intramuscular protocol. So it goes intramuscular instead of subcut, because obviously patients are dehydrated, the absorption subcut is going to be really unreliable. Use the appropriate syringe, because I've been caught out by that before, because obviously got the yellow top and the red top, so it's got to be the 100 unit syringe. You start with the 0.2 units per kilo of insulin IM, and then you want to be checking the blood glucose every hour, because depending on how quickly or slowly that blood glucose is dropping, that determines what the next dose of intramuscular insulin is going to be. So with any form of insulin therapy, we want to avoid dropping the blood glucose by more than 4 millimoles per hour, because the trouble is then you can get cerebral edema. So it wants to be nice and slow. And it's the same endpoint. So once you've got a blood glucose below 14, we want to be starting a glucose CRI. And with the IM protocol, you can then kind of spread out the duration of the IM injections, so to every 4 hours. Downside to this is that you kind of have less control over the insulin delivery, and you're, I suppose, jabbing your patients more than with the CRI method. But some people prefer one method, some people prefer the other. We do tend to use a variable rate neutral insulin CRI at Swift. What we do is we add 2.2 units per kilo of insulin to a 250 ml bag of fluid. And then run the first, this is really important, you've got to run the first 50 mils via the extension line and discard it, because insulin binds to plastic. So when you've run it all through, you then know that that plastic's fully saturated, and then the next lot of fluid that goes into the patient is going to have active insulin in it. You want to discard the bag after 24 hours, but to be honest, the patient should be on the CRI after 24 hours anyway. And we always start on a standard rate of 10 mil per hour. And this isn't per kilo per hour, this is a standard rate of 10 mil for all patients. And then there's going to be a chart on the next slide that explains at what point we then based on the blood glucose. So with the CRI protocol, we're actually checking the blood glucose every 2 hours. And based on what we get, we're going to be altering the rate of the insulin and altering the rate of the glucose. And again, like we said on the previous slide, aim for a maximum decrease in glucose of 4 millimole per litre per hour. So next CRI to add into the mix is a glucose CRI. Now it seems really counterintuitive to give what is essentially a hypoglycemic patient glucose, but the important thing is the end goal of treatment is not to just reduce the blood glucose levels, it's to stop the production of ketone bodies and metabolize the ketone bodies in the system. Because as we said earlier, the ketone bodies are the acids, and that's what's then causing this metabolic acidosis. So we want to just shift all of those ketone bodies from the circulation. But in order to do that and to signal to the body that actually we're not relying on ketones anymore, you need to give the cells a reliable source of glucose and insulin. So in order to keep giving the insulin to the patient until we've metabolized all the ketone bodies and can then start on the long-acting insulin, you have to add in a glucose CRI to stop the patient from getting hypoglycemic. Does that make sense? So at the point where your patient's blood glucose is less than 14, that's when you want to add in the glucose CRI. So probably start with a 2.5% solution. And then, as per what the blood glucose is every 2 hours, we're going to adjust the rates here. So just to explain this here, and this is, we have like a standard protocol that we basically follow. So we'll print it off, we'll put it on the patient's kennel, so anyone that's checking the blood glucose can kind of work out what rate of CRI the patient needs to be on. So patient's still hypoglycemic, blood glucose is above 14, they're still on the 10 ml per hour of insulin. Starting to drop to below 14, we want to add in that 2.5% glucose solution and drop the insulin rate. Again, glucose is dropping further, so drop that insulin further. And if it's going really quite low, but your patient's still quite poorly, then you can, if you wanted to, you can increase the concentration of the glucose CRI and obviously reduce the insulin, and then stop altogether if the patient's super hypoglycemic. And again, there's kind of a little bit of flexibility here. I have had patients before that the glucose level just isn't dropping, so I've doubled the rate of insulin in the bag, or increased the rate of the insulin delivery, and some patients drop really quickly, so you need to be actually then almost going back up, or going back down, sorry, and you kind of need to be a little bit flexible with it. But generally I'd say it should follow a lovely trend of a gradual decrease in glucose level, and then you're just tinkering with the CRIs accordingly. So other electrolyte disturbances. In some cases, you might find that you feel like you're giving the patient loads of potassium, and no matter what you give it, it just doesn't seem to be touching the sides, and they're still really hypokalemic. Now, I appreciate not many places have the ability to check magnesium in-house, but sometimes hypomagnesemia can be one of the main causes of a refractory hypokalemia, so it's okay to supplement the magnesium to see if it helps. And it does, to be fair, within 6 hours makes a huge difference. And the CRI rate of magnesium supplementation is 0.5 millimoles per kilo per day, which is equivalent to 1 milliequivalent per kilo per day. And you give that for 24 to 48 hours. Hypophosphatemia as well. So can be very serious, this actually. Phosphate is obviously essential for ATP metabolism. So if your patient's severely hypophosphatemic, they can get neurological signs or muscular weakness, and in cats in particular, you can get the hemolytic anemia. So I tend to use a ballpark figure of if the phosphate's below 0.6, I'd supplement and mix it in saline rather than anything else. So bicarb for severe acidosis. So I'd classify severe acidosis as below 7.1, so that's when it can be life-threatening. Or if it's higher than this and there's evidence of cardiovascular compromise from the acidosis, such as hypotension or arrhythmias, they would both be grounds to supplement with bicarb. I mean, as we touched on earlier, hopefully the treatment of DKA will naturally cause the pH to go back to normal and increase to what is a normal pH level and clear the acids in the system. But if you're not finding that and you need to supplement, then you can give a bolus of bicarb. So the bicarbonate calculation, so you can work out the mils required by timesing the base excess by the body weight times 0.3. But we actually only give a quarter to a third of this volume, and we dilute it with water for injection and give it over 5 to 10 minutes. And actually, the reason we're really conservative with this is because we don't want to overcorrect and cause the patient to become alkalemic. And actually, there can be some quite serious side effects of the bicarb administration. So you can get CNS acidosis and worsening hypokalemia. So we only use it if we really need to. Try and stay away if you can, but it also is life-saving when you do need it, so it's useful to have the calculation there. And the way it works is the bicarb, the give intravenously, binds with the acids, and then that's eliminated from the body in the form of carbon dioxide. So if your patient's already hypercapnic and it's not managing to expel the carbon dioxide, might be a Frenchie, might be it's got other ventilatory issues, then your bicarb's not going to do anything because we can't eliminate it from the body, so then it would be contraindicated. So other supportive treatment, as per the patient and their individual requirements, might be analgesia, might be antiemetics or prokinetics, might be antibiotics, and it might be a feeding tube. So as a rough guide for monitoring, I'd be checking the blood glucose every 2 hours. Do you know, I actually forgot to say on one of the previous slides, but we love using the continuous glucose monitors. So the Freestyle Libras, which humans use, they're really helpful. There is now a veterinary licensed product, the Woodley's Insight, so we've swapped over to that. But essentially, it minimises the number of times you need to jab your patient to get a blood glucose sample. And they tolerate it really well. It takes about 2 seconds to place. I think they're at £100 to £150, so it's obviously a bit more expensive, but in theory they should stay on the patient for 1 to 2 weeks. So it's then really helpful for a week down the line when when we need to kind of work out what the long-term insulin dose is. It means that clients can do the glucose curves at home. So to be honest, when they first come in, we always, if the patient can afford it and they're up for it, we always put a CGM on our patients. But in terms of monitoring, blood glucose every 2 hours, that'd be for the CRI protocol. For the IM protocol, initially we want to be doing it kind of every hour, because obviously every hour we want to be giving that jab. Check the blood gases every 4 to 6 hours. Obviously you might need to do it more frequently if you are finding that they're getting a worsening hypokalemia or you're supplementing that really closely. And ketones every 12 hours, just to see that trend that they are declining. And then when do you want to when do you want to switch to the long-acting insulin? So long-acting being your can insulin or Prozinc typically. And that will be when the patient is no longer acidotic, the ketones are reducing, and the patient is eating. So obviously we work nights, so it's again being mindful of actually when's a good time for the owners to continue this every 12 hours going forward. So if you find that actually the patient's doing way better at 4 AM, can start on the long-acting insulin, but actually we want to maybe delay that till 8. You can either use the CRIs at kind of looser glycemic control, or with the IM protocol you can give them a subcut injection which lasts kind of like 4 to 6 hours as a bit of a stopgap, and then just start them on the long-acting insulin when's an appropriate time. And obviously we're not aiming for tight glycemic control immediately after the patient's had diabetic ketoacidosis. So long as they are well in themselves, that is the most important thing, to discharge them. And then we want to be reassessing the long-term insulin dose in about a week's time. So however, people have different ways of doing this. Some people go off clinical signs, some people like a glucose curve. Obviously if it's at home, they're less stressful, it's less white coat effect. But don't be disheartened if your patient's not got lovely looking glucose levels by the time they go home. So Senvelgo. Cats on Senvelgo, that's why within the first kind of 1 to 2 weeks of popping them on it, we want to keep a really close eye on them because they can still develop DKA. I mean, Senvelgo is an oral treatment that we can give diabetic cats, and it effectively prevents the reabsorption of glucose in the nephrons. So you get massive glucoseuria, which means that the patient's blood glucose levels are kind of within normal reference range. It works because cats typically have your type 2 diabetes, but so type 2 being relative insulin deficiency rather than total insulin deficiency. But if they do happen to fall into that category, which is a type 1 diabetes where they just don't produce insulin, then they can still develop ketoacidosis. And if they do present with a ketoacidosis, just treat them as any other DKA case, but just know that Senvelgo is not appropriate for them. They need to go on to the long-acting treatment going forward. And there will be a small subset of cats that do fall into this category. And then another condition, which is fairly rare, and thankfully so, because it's not very nice to treat and it's not got a fantastic prognosis, but it's called hyperglycemic hyperosmolar syndrome. So these are poorly controlled diabetic patients, and they present really unwell. So often they're very obtunded, very flat, very dehydrated and hypovolemic. But if you do bloods, and you're probably thinking it's a walking, talking DKA, got really high blood glucose levels, but they don't have the ketoacidosis, it could be this HHS. So they don't tip into DKA because they somehow have enough insulin to get by, but they have such high glucose levels that it's the hyperosmolarity that causes the issues. And you can again do this complicated calculation to work out what the serum osmolarity is, and if it's above 320 milliosmoles, then you're probably looking at a HHS. And the difficulty with treating this is you want to replace the fluid loss really slowly, the free water loss, because their electrolytes are all over the place and they're very susceptible to neurological signs. You want to replace the electrolytes very slowly, you want to drop the glucose levels very slowly, and you probably will be using insulin in these patients, but just a lot more cautiously. So not great to treat, but